This is EM Cases EM Quick Hits podcast. Quick, let's get on with it. EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for general information and educational purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. Unless stated otherwise, the opinions expressed by the hosts or guests are made in their individual capacity, not on behalf of the Institute nor Medicine Cases. We just announced a few days before this podcast was published that we've opened up 150 free tickets to the online International EM Cases Summit to physicians who are currently practicing in a low-income country. We're doing this to help bring together the worldwide EM community in the spirit of equity and inclusion. If you're one of these physicians, you'll need to submit proof of current employment. Please head over to emcasessummit.com to register for the main event on a first-come, first-served basis. On this month's EM Quick Hits, as part of our Best of University of Toronto series, we have a special guest, the chief of the ED at North York General Hospital, where I work, Dr. Kevin Wasko. Welcome to EM Cases, Dr. Wasko.
Thank you, Anton. It's great to be here.
All right, I'm not going to give away the topic up front. Instead, let's just present a quick case. It's 4 a.m. on a Saturday night at rural Janus General, and an otherwise healthy 32-year-old woman comes in, and she's day 13 post-uncomplicated tonsillectomy for recurrent tonsillitis with peritonsillar abscess. She tells you that she woke up at 11:30 p.m. coughing up a bit of blood. She feels a constant trickling of blood down the back of her throat since then. On exam, her vitals are normal except for a heart rate of 115, and when you take a look at her pharynx, you see exactly what she described, a trickling of bright red blood from the left tonsillar fossa. So, we have a young, healthy woman with about 5 hours of constant post-op tonsillar fossa bleeding, and we're 3 hours by road to a hospital that has an ENT on call. So first, Dr. Wasko, let's talk about why these patients bleed. This patient is 2 weeks post-tonsillectomy. Most of the bleeds I've seen have been within the first day or so. Why do these patients bleed at these different times? When should we be thinking about patients bleeding after having a tonsillectomy?
So there's two classifications of post-tonsillectomy bleeds. They're the primary bleeds that occur in 24 hours or less, and they are generally bleeds that are occurring because something happened intraoperatively, or they may have an undiagnosed coagulopathy. And then there are those in the secondary bleed classification that occur after 24 hours, usually up to 14 days, and they're generally in the 5 to 7 post-op days. These occur because the fibrin clot has been sloughed off and it's exposed the tissues underneath, and bleeding occurs. Oftentimes they start as a trickling bleed, but they can be very brisk and they can be massive bleeds. And so I think the most important thing to realize is that even though some bleeds start as a trickle, they can be a herald bleed and turn into a massive bleed. Also, if a bleed has persisted for this many hours, even if it is a trickle, it may be unlikely to stop just with the temporizing measures and would need definitive care from an ear, nose, and throat surgeon.
Okay. So suffice to say that pretty much all of these patients are going to need definitive care with ENT. So getting ENT involved early is always a good idea. Don't delay that call to ENT. All right, so you're 3 hours away from an ENT surgeon. What are your treatment options at 4 a.m. on a Saturday night? What are you going to do for this patient?
So for these patients, I think they need to be approached in a 3-prong approach. First is focus on resuscitation. Second is getting help, getting them transported early. And number 3 is temporizing measures that really just buy you time and hopefully slow or stop the bleeding while you're awaiting transport. In terms of the temporizing measures, there are many options. So your options for temporizing measures include direct pressure, topical agents, and TXA that can be provided in a number of different ways.
So I love that 3-pronged approach. There's resuscitation, there's making sure you get help early because, again, these patients need definitive care regardless of whether you can temporarily stop the bleeding or not, and the temporizing measures. And we'll get into all of these in just a minute. So what did you do in this case?
So first things first, I went in the room, made sure that the patient was in a seated position and a position of comfort so that I was able to get a good look and identify where the bleeding was coming from and how briskly the bleeding was happening. I did initiate a call to the tertiary center to an ear, nose, and throat surgeon so that we could get transport arranged, and that was in the works as I then moved to the next steps to try to address the bleeding. The first thing that I did was apply direct pressure. And I did this almost instinctively by just putting gauze back against the spot of the bleeding on the tonsil. And that didn't go well. I needed to regroup and see how I was going to approach this in a better way. I used topical lidocaine spray, and then I actually used gauze soaked in lidocaine with epinephrine and applied direct pressure. At the same time, the nurses were obtaining IV access, and we gave IV TXA. We also gave IV ondansetron because the last thing that I wanted was the patient to be vomiting, particularly as I was poking around in the back of their throat and causing their gag reflex to kick in. I gave nebulized TXA while I was preparing my airway materials in case I would need to intubate. I found that was an easy intervention that I could just put on the patient, that I was doing something active while it still freed me up to prepare for the next steps.
All right. Yeah, I want to talk a little bit more about TXA. So you've got nebulized TXA, you've got local topical TXA, and you've got IV TXA. None of these have great evidence, but there have been some reports, case series, and small studies. How do you suggest we think about which one of these to use or which combination of these to use in these cases?
So one of the most important things that we can do is apply direct pressure, and we're going to apply direct pressure anyway. So soaking that gauze in TXA and then applying pressure is an easy thing to do, and I think that would be probably the first place that you could use TXA. As I said, I gave nebulized TXA because it was something that I could just put on and then get other aspects ready, and I think that's something to consider as an active process that isn't actively taking up your time. And then the IV TXA can be given by nursing and a task that's delegated to someone else in the resuscitation team. Again, all of these are lacking in evidence in this indication, but there's no evidence to suggest that they're harmful for this reason. And there are small studies, particularly in the nebulized TXA, that are being done and showing promise.
Let's step up the case a bit and say that the patient starts to gag on the blood and looks like they're aspirating, and then they start desatting and they're tiring, and you decide that you need to intubate to protect the airway. What's your airway strategy going to be? And what else are you going to add to your management?
First thing, call for help if you have someone that is at your disposal to call, whether it's anesthesia colleague or a second physician. I know for many of us who worked in rural places, that's not a luxury that we have, but if you have it, call. These can be very messy airways. They are not necessarily technically difficult from an anatomical perspective. So it's important to have adequate suction, whether you're using a decanto suction, a meconium aspirator. There's a lot of approaches that have been outlined in the Massive Hemoptysis EM Cases podcast that could be used in this case. And really, suction is so important. So having the suction available, clearing the airway from the bleeding as much as possible so that you can have a good look with video laryngoscopy, and then taking an RSI approach, which is what we're all used to.
Great. And then in terms of what you're going to order for blood work, what are the things you're thinking about in the back of your head? Like, could this be a bleeding disorder? What else are you going to be doing before this patient gets transferred to ENT?
Yeah, so in terms of labs, getting a hemoglobin level, knowing where they're sitting, getting a group and screen. If it's been a massive bleed, maybe cross-matching blood. If they're on anticoagulants, giving prothrombin complex, getting a fibrinogen level are all things that you're thinking about depending on the patient. Those labs will be wanted by your center where you're sending the patient as well. So getting them drawn off, even if they're not going to be back by the time the patient's still in your care. And then in terms of thinking of what this could be in terms of an unidentified coagulopathy, particularly in your younger patients, it should be something that's in the back of your head. And in those patients, you could consider giving IV DDAVP.
All right, and that would be for an undiagnosed von Willebrand's, I'm assuming.
Yes, that's right.
Okay. So yeah, a lot of these kids, 7, 8, 9, 10-year-olds will come in and they have undiagnosed von Willebrand's. And if they're really bleeding more than you'd expect, that's something you should think in the back of your head and consider giving one dose of DDAVP, which doesn't have much of a downside either and could be life-saving. All right. So how did the patient do in the end?
So the patient eventually did go out by air ambulance to the tertiary center. The patient was not bleeding at the time of transport and did not bleed in transport, which I was glad to hear afterwards. They were seen immediately by an ear, nose, and throat surgeon at the tertiary center. A large clot was identified, removed, and the patient was cauterized in the operating room. And so in the end, all ended well.
Fantastic. All right, let's bring it all home with some key take-home points then. So first, to understand that there's primary and secondary post-tonsillectomy bleeds. The primary ones happen in the first 24 hours or so. And for those ones, you should be thinking about maybe an underlying bleeding disorder. And those ones are often because of intraoperative factors. And then the secondary bleeds that happen after 24 hours, typically around 5 to 7 days, but can be up to 2 weeks. Those ones are because of the clot that comes off. They can be little trickling bleeds that don't look bad. But again, one of the key points is to get your ENT surgeon on the phone early, because pretty much all of these patients are going to need definitive source control, even if the bleeding settles down in the emergency department. We can break the approach to these patients down in 3 prongs. There's the resuscitation, there's getting your help early from ENT, and there's the temporizing measures. In terms of resuscitation, don't forget to position the patient sitting upright in the position of comfort, and that we're going to apply pretty much the same airway strategy as we do in the massive hemoptysis patient. It's RSI with video, and suctioning is key, preferably with a decanto catheter or a meconium aspirator setup. For temporizing measures, you want to apply direct pressure, and your medication options are TXA and epinephrine. TXA can be given nebulized. It can be soaked in gauze and applied directly to the bleed, or it can be given IV. And you might want to throw on the nebulizer as you're getting everything else ready. And just like any life-threatening bleed, if there's DOACs on board, you're considering PCCs and vitamin K. You might be giving red cells, particularly if your patient has, like a shock index of more than 1. And don't forget to get that fibrinogen level if you can get it, because later on, if the bleeding is massive, they may require fibrinogen concentrate. And one bonus little clinical pearl, for topical application of meds and for trying to apply gauze to the area of bleeding, one thing I found useful is using one of those see-through plastic vaginal speculums with a light built into it, because that gives you great exposure, it gives you great lighting, and it gives you great access just to that point of maximal bleeding, rather than putting a headlamp on and trying to get the patient to open their mouth. And it's a nice little trick that can be used for these patients. Any other last words of wisdom you want to leave our listeners with, Dr. Wasko?
I think just really emphasizing that all of the things that we give are really temporizing measures, and what we need to equally focus on is trying to get these patients to definitive care, which is to, in some cases, tertiary center and getting transport arranged. All of the efforts that we put in to stop bleeding are not necessarily going to fix the patient. They're just going to buy them time until they can get to where they need to be.
Thank you so much, Dr. Wasko. We're going to continue with our post-operative complications theme. Here's Brit Long on what we need to know about post-coronary artery bypass graft surgery infection, post-CABG infection. But before we get to that, this episode is sponsored by BetterHelp. It's Halloween season, and we all have things that scare us occasionally, right? What scares you? Talk therapy is a great tool for facing your fears and discovering ways to overcome them. If you don't talk about your fears, they'll probably fester and grow. Therapy can help you overcome those fears and make you better prepared to deal with adversity in the future. And BetterHelp makes it easy. They provide talk therapy online and they're flexible to fit your busy schedule. Overcome your fears with BetterHelp so that you can handle scary situations going forward. Visit betterhelp.com/encases today to get 10% off your first month. That's BetterHelp, HELP.com/emcases.
I recently took care of a 75-year-old male who came in with fevers, chills, and some chest pain. This seems pretty straightforward. We see this type of patient fairly routinely. But there was one wrench thrown into the mix here. About a week ago, he had undergone open coronary artery bypass surgery. On exam, he was febrile and tachycardic. He had a sternotomy incision that was tender to palpation. There was redness along the incision site, and there was some purulent drainage. Post-bypass surgery patients can be incredibly complex, and there's a risk of some major complications. This is one of those areas where the more you know, the better you can care for these patients. One of the most common diagnoses during the post-op period is a surgical site infection. In this quick hits episode, we're going to look at superficial and deep sternal wound infections. Post-cardiac surgical site infections come in two flavors. There's superficial, and then there's deep sternal wound infections. Superficial sternal wound infections involve the skin, the subcutaneous tissue, and the pectoralis fascia. Deep sternal infections are a different animal. They involve the mediastinum, the pericardium, and myocardium, and they can cause some significant issues. Deep infections occur in up to 2% of post-cardiac surgery patients, but they have a much higher mortality rate. That's anywhere between 10 up to 30%. Mediastinitis is the more common deep infection, and it significantly increases the short-term and the long-term mortality for these patients. So, how do we diagnose these patients in the ED? The diagnosis is primarily going to be clinical, but it can be difficult to differentiate between superficial infections and those deep sternal infections. Both superficial and deep infections usually occur in the first 2 weeks to month after surgery. Patients can have fever, tachycardia, they may have chest pain, and there's often redness along the incision site. With deep infections, you can find instability of the sternum and then also purulent drainage coming from the wound. Sternal instability is excessive movement along the sternum due to disruption of the wires. On exam, you might find popping, clicking, or you can even feel the sternum move with palpation over the surgical site. There is a set of diagnostic criteria for deep sternal wound infections that comes from the CDC. These are, number 1, an organism isolated from culture of mediastinal fluid or tissue. Number 2, evidence of mediastinitis seen during operation. Or number 3, presence of either chest pain, sternal instability, or fever, and purulent drainage from the mediastinum or a culture of the mediastinal area. That third criterion is what we can use in the ED for diagnosis. But really, the key here is to assume a deep sternal infection if there is any sign of a surgical site infection. Imaging is going to be a major part of the diagnosis. CT chest with IV contrast is the imaging modality of choice, and it can help determine if the infection is superficial or if it's deep. The CT can measure the depth of the infection, it can evaluate for any sternal dehiscence, and it has high sensitivity for ruling out deep space infections. It also helps your surgical colleagues with any operative planning. Determining the causative organism is also important here. This is one of those times where wound cultures are recommended. They identify the organism in close to 75% of cases. This increases to over 80% of cases when blood cultures are also obtained. The most common organisms found on culture are Staph aureus, Streptococcus species, Pseudomonas, and finally Enterobacter species. Once we have the diagnosis, what about treatment? First, speak with the patient's surgeon. Management of a superficial infection is similar to any other abscess or cellulitis. If there's an abscess, they need incision and drainage, antibiotics, and local wound care, but this is usually guided by the surgical team. Deep sternal wounds are different. They need IV antibiotics and then the operating room, potentially for a revision. You won't be debriding these in the ED, but you can start broad-spectrum antibiotics. This usually includes a broad-spectrum beta-lactam combined with something for coverage of MRSA like vancomycin. Your surgical colleagues may want some other antibiotics as well, like aminoglycosides. Also keep in mind that these patients are at risk for infection of the venous harvesting site or post-venectomy cellulitis. This usually occurs months to years after the saphenous venectomy, and it can be recurrent. These patients will present with erythema and swelling along the medial aspect of the mid-tibial region along that venectomy site. Treat these patients like every other patient with cellulitis, but recurrent cases may need chronic suppressive antibiotic therapy. In summary, surgical site infections after open coronary artery bypass surgery come in two flavors. There's superficial sternal infections and deep infections. The diagnosis of post-op infections can be clinical, but CT chest with IV contrast, wound cultures, and blood cultures are important parts of your evaluation for a deep sternal infection. Speak with the surgeon and get antibiotics on board for these patients.
Beautifully summarized. Thank you so much, Dr. Long. So the key message here is that what looks like a simple surgical incision infection or cellulitis should be presumed to be a deep chest infection until proven otherwise. All right, next up is Swami on the evidence for using gum elastic bougies in airway management, the importance of proper training, and some great tips and pitfalls for their use.
We've seen so many advances in airway management over the last 2 decades. When I started residency in 2005, it was non-rebreather at 15 liters for pre-ox, atominate and sucks for RSI meds, cricoid pressure to prevent aspiration, no bagging after paralysis, direct laryngoscopy with delivery of an ET tube loaded with a malleable stylet. Nowadays, cricoid pressure is out, ketamine and rock is all the rage. Providing positive pressure ventilation for pre-ox and during the apneic phase has been shown to be beneficial. Video laryngoscopy has been shown time and time again to be superior to direct laryngoscopy, and the gum elastic bougie has to a significant extent replaced the old stylets. But I'm surprised that the bougie hasn't had a wider uptake. The BEAM study by Driver and colleagues in 2018 showed a marked improvement in first pass success rate when using a bougie compared to the standard approach. 96% versus 82%, a 14% absolute difference, giving a number needed to treat of just 7. Seems pretty definitive, but the same group published the Bougie study 3 years later, which showed no significant difference between a Bougie first and a standard approach for first pass success. That second study is often cited by folks who haven't embraced the Bougie, and on the face of it, I do understand why. The Bougie study in 2021 was a multi-center study, whereas BEAM was only in a single center. And many argue that the Bougie study has more external validity, a bougie first approach is only better in the single center where beam was done. I think the truth, though, is pretty different from that conclusion. The truth is that a bougie first approach is superior in skilled hands. At Hennepin County, where the beam trial was performed and where Bougie was found to be superior, the standard intubating approach prior to the study was to use a Bougie first. The intubators were skilled with the Bougie, and that's why there was a very high first pass success rate. 96% first pass success, far higher than the overall first pass success rate that we see in the multi-center Bougie study, which floated around 80%. These two studies demonstrate that number one, the Bougie first approach is superior, and that two, it's only superior if you have skill with a Bougie. To me, that means that we should be doing all tubes with a Bougie to build the superior skill set. This makes even more sense when we consider the fact that many folks who don't use the Bougie for every tube do consider it to be their rescue option. A rescue technique only has value if you have skill with that approach, and that skill can only be developed by practicing it. All of this means that we have to understand the Bougie, how it works, and how to troubleshoot when using it. Much of mastering the Bougie lies in watching videos, getting your hands on it, and practicing. As you gain skill using it, there are, though, some common pitfalls to consider and tips to avoid them. Most of us will have access to flexible Bougies with a coude tip. These devices will temporarily hold a curved shape, but they can't be given a permanent bend. There are devices with articulating tips that can be steered using sliders along the length of the Bougie, but honestly, these have never been stocked in any place I've worked, so I can't really give any advice on using them. Because the standard Bougie doesn't hold a curve, you really can't use these devices with a hyperangulated geometry video laryngoscope. You can use it with a standard Macintosh direct laryngoscopy blade or a standard geometry video laryngoscope. The inability to hold any kind of a curve is also very different from an ET tube with a standard stylet. As a result of this, one of the places that people run into trouble with a Bougie is that when it's coming in, it lies posterior to the cords. It's hard then to angle it up to where you need to put it. To fix this issue, we need to be able to make real-time micro adjustments in the direction the coude tip is going. The way to do this is by holding the Bougie with a scissor grip. Hold the Bougie between your second and third digits with the third digit posterior. This positioning allows you to use your third digit as a fulcrum. By applying downward pressure on your second digit, the Bougie tip will move anteriorly. That's a bit hard to describe. We'll have a link in the show notes to a short reel on Instagram showing how to make this happen. Another big pitfall is in taking your eye off the Bougie. I often see folks look away from the cords after passing the Bougie between them, but this increases the risk that the Bougie comes out without the airway operator knowing that it's come out. The best approach is to pass the Bougie and lock your eyes on the cords. Instead of taking your eyes off the prize to thread a tube over the Bougie, designate an assistant to load the tube onto the Bougie and advance it to the lip where you can then take over and complete tube delivery. There are approaches for single operator with no assistance, and once again, we've got a video link in the show notes to an Instagram reel showing one approach. Similarly, I've seen operators remove the laryngoscope prior to delivery of the tube over the Bougie. This can lead to dislodgement of the Bougie, but more commonly, it collapses the airway structures, prohibiting advancement of the tube over the Bougie. Easy fix once again, don't pull out the laryngoscope until the ET tube is delivered between the cords. On occasion, the Bougie's coude tip will get stuck on the anterior tracheal rings, limiting advancement. This is easy to remedy by simply rotating the Bougie 90 degrees in either direction. That disengages the tip from the rings and further advancement can occur. Another common occurrence is that the ET tube can't advance over the Bougie because it gets stuck on the arytenoids. Rotation fixes this issue as well. Back the tube up about a centimeter or so, and then rotate 90 degrees counterclockwise to disengage the tube tip. In expert hands, the Bougie increases first pass success. It improves our approach to airway management. The key word there is expert. You can't expect to be good at using a Bougie unless you practice using a Bougie. You can't rely on the Bougie to save you in a difficult tube unless you're an expert in its use. The best way to become an expert is to use it on every intubation, and these are just some of the tips on how to use the Bougie better.
Do you dread doing your clinical notes every shift? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed is an AI scribe that listens, transcribes, and writes medical documentation for you. Notes are written in your style and ready the moment the patient encounter is over. Just imagine leaving work at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence can't replace you, but it can do the administrative work that no human should be subjected to. All the magic happens in just a few clicks so that you can spend less energy on charting and more time on doing what you do best. Freed learns your style over time, just like a human scribe, and it'll never quit on you. More than 6,000 of your clinician colleagues already use Freed AI. Get back to spending your clinical time caring for patients and let Freed AI do the rest. Head over to getfreed.ai and use the code EMC50 to receive $50 off your first month with Freed. That's getfreed.ai with the code EMC50.
You're working away in the majors department when you get an alert for a potential hip fracture. So you go quickly to assess the patient, see if you can get them started on the pathway to expedite their movement through the department with imaging, analgesia, and management as per the guidelines. Oh, the beauty of preordained guidelines. But the triage nurse informs you that when you arrive, you have an 83-year-old female who is out at a country folk concert with her family. She's after slipping going down the steps, is complaining of pain in her right groin and her hip. She's unable to mobilise since the incident. There was no head injury and no secondary injury. You stick your head around the curtain and see a very pleasant woman sitting up at a 45-degree angle in the bed, looking reasonably comfortable, all things considered. She introduces herself as Anne and shakes your hand vigorously. You examine her and note that she has some tenderness in the right groin, but there's no limb length discrepancy or rotation. Both lower legs are lying in a neutral position. There's no bruising or wounds, and she's neurovascularly intact. Importantly, she is able to straight leg raise, albeit with some pain. She's vitally stable and proudly remarks that she's very healthy at baseline, is on 1 blood pressure medication and a blood thinner for atrial fibrillation. You're less concerned about a hip fracture, so you just request an X-ray pelvis to assess what you might be dealing with and take her off the pathway. As you have a look at the images afterwards, you notice quite a distinct irregularity with a displacement in the border of both the right superior and inferior pubic rami. There's no noticeable hip or acetabular fracture, but it looks painful. You pop in an IV cannula, give her some analgesia, draw off a type and screen, venous blood gas, and some baseline bloods. In the back of your mind, you recognise that this lady will be in quite a bit of discomfort, and so will need an admission for a multidisciplinary approach with analgesia, a mobility assessment, and rehabilitation. She's chatting away about her granddaughter, who studied medicine, and all seems peaceful. But as with all things, some things can change. As you're running her blood gas, the nursing staff come to tell you that she's had a syncopal episode while attempting to use the commode. Things have changed. This time when you go and see her, her ashen face looks very different. She's pale and seems fatigued. Her heart rate is now 130 beats per minute, irregularly irregular, and her blood pressure is 80/65. You transfer her to your resuscitation area. A 12-lead ECG is now showing fast atrial fibrillation. She denies any chest pain, but the pain in her pelvis is increasing. She feels lightheaded and dizzy. You complete a full head-to-toe assessment to see if there is any other stigmata of trauma or primary collapse that may be contributing to her deterioration. But there's no change. Venous blood gas shows a mild metabolic acidosis with a hemoglobin of 8.7. From her previous attendance, you have a hemoglobin of 10.2 as her baseline. Lactate is 3.5, and base excess is -4. That's a lot of information. So let's go back. We have an 83-year-old female with a new right-sided superior and inferior pubic rami fractures. She's had a significant deterioration, has a shock index of 1.6. Her hemoglobin has dropped, and she has a metabolic acidosis. You correctly assess that this woman has to be bleeding into her pelvis. You start transfusing 2 units of red cells and order a CT angiogram of her pelvis. An arterial line is inserted for invasive blood pressure monitoring, and thinking that you might need to reverse her direct oral anticoagulation. As she starts to stabilise with the red cells, you transfer her for CT. and the radiology team calls you shortly afterwards as you continue to transfuse the patient. She's definitely blood product dependent at the moment, and you're really struggling to maintain a decent perfusion map. This woman, indeed, has a retroperitoneal pelvic hematoma and a vascular injury. There is an active blush from a corona mortis vessel, the crown of death. Ominous. Luckily, you have access to interventional radiology, who take her for IR-guided embolization, and subsequently a completely different Anne returns to your emergency department. She is admitted shortly afterwards for rehabilitation and analgesia with a stable blood pressure. Good save. Pubic rami fractures are really tricky and commonly underestimated as an insufficiency fracture that are usually stable and not requiring any intervention. The evidence for mortality and patient outcomes is limited to only a few retrospective single-centered studies, but they can have huge dramatic impacts on elderly patients' outcomes and morbidity, mortality, and mobility in the subsequent 5 years. There is some limited evidence to provide a standard approach to investigating and managing these patients. Importantly, one small study did show that complications for these patients in hospital do include things like hospital-acquired infections, venous thromboembolism, and importantly, 40% of patients fail to return to pre-injury functional status. In fact, nearly 50% of patients lost their independent mobility status.
That, of course, was Dr. Leah Flannigan, co-host of Case Reports. Thank you, Dr. Flannigan, for that reminder that it doesn't necessarily take a severe high-energy mechanism for pelvic fractures to bleed badly. While far from everyone with a pelvic fracture requires a CT angiogram of the abdomen and pelvis to screen for a bleed, if the clinical picture suggests an occult hemorrhage in a patient with a pubic ramus fracture, this particular complication of pelvic fractures should be on your list, even in a patient who comes in after a ground level fall. All right, talking about trauma, our go-to trauma expert, Dr. Andrew Petrosoniak, is up next. Petro is not only a trauma team leader, but has made a name for himself as an expert on team resuscitation and debriefing. In fact, he'll be giving a talk on the topic at the EM Cases Summit, which depending on when you're listening to this podcast, is just in a few weeks, November 21st to 23rd. And if you sign up for the small group simulation sessions, he'll be one of our expert debriefers who will give you specific, valuable feedback on your resuscitations tailored for your practice. Spaces are filling up fast, so head over to emcasessummit.com to register before it's too late. And before we get to Petro, a quick word from one of our sponsors, Metricade. Since 2015, I've been using Metricade, the incredible self-scheduling system that has made my life and the lives of my colleagues so much easier. Metricade can really help minimize the drawbacks of shift work we all know so well by not only ensuring equitable distribution of shifts, but also integrating circadian rhythm-friendly recovery time into their algorithms. They minimize my sleep deprivation, which allows me to be a better EM doc on shift. I can take better care of my patients and still have energy left after my shifts to enjoy other aspects of my life. Check out metricade.com/emcases for more details on how this awesome scheduling system works.
This is going to be a bit different than my typical trauma podcasts. Instead, we're going to focus on what happens shortly after a trauma resuscitation. In fact, I'd argue that what we're going to talk about is as important as the resuscitation itself. Unfortunately, though, it's not something applied nearly as often as it should be. And to be honest, this is the secret sauce to high-performing teams and successful resuscitations. What is it, you ask? Clinical debriefing. You may be wondering, why is this necessary? Sure, you've probably done a debrief when you ran a simulation, but a debrief in the clinical arena? Really? I know what you're thinking. Why? We're too busy. We don't have time. We've got patients to see. And honestly, this isn't going to help me become a better doctor. I don't want to sit around and talk about feelings. All of these things I've heard when I've discussed the topic, so they're not new to me. But if you've gotten this far, then hopefully you'll listen as I try and convince you otherwise. We'll touch on each of these barriers to debriefing and how you can overcome them. I'm not going to lie, I don't debrief every big case or bad outcome, but I do commit to debriefing at least 2 more times than I did the year before. That's what I think is reasonable for me. Just like you, I work in a busy ED, and it's not easy to get people to buy in. But 95% of the time when I suggest we run a debrief, we have an incredible participation level. The feedback days afterwards is universally positive, and that's what keeps me motivated to keep debriefing as part of my clinical practice. So let's get into it. Here's a case to kind of guide my take on this concept. You're working in a moderate-sized community hospital. You just finished a pre-taxing trauma resuscitation, a 64-year-old involved in an MVC and required intubation, a chest tube, a pelvic binder, a couple of units of blood, some TXA. Patient stabilized. You got them transported by a team of critical care paramedics to your regional trauma hospital. Took you the better part of an hour. Your team consists of you, 3 nurses, and a respiratory therapist. A fellow physician helped with several of the procedures, and a clerical team member coordinated contact with the accepting hospital. From your perspective, things went really well. But you just listened to this podcast, so you're wondering, maybe debriefing might be valuable. We're going to talk about why debrief, when should we debrief, a few barriers, and how to actually make it happen. So let's start with the first question. Why debrief at all? Because it might be the most valuable thing you can do to improve team performance over time. Here's some summarized data. A meta-analysis from 2013 of both medical and non-medical teams found that organizations can improve both individual and team performance by 20 to 25%, simply by debriefing. Imagine if we started the conversation with this data. I have a new treatment or management tactic that will improve team performance by 20%. Pretty sure you wouldn't hesitate to implement that. Number 2, to enhance learning. Effectively, debriefing is a form of reflection. If I asked you to get better at shooting a basketball, but after you shot, you close your eyes so you never get to see what happens, and then you could really not make any changes to your shot that positively impacts your performance, it's unlikely that you'd think that that's an effective performance strategy. Instead, you'd probably want to watch your shot, make adjustments as you reflect whether it goes in and how the shooting motion feels. Debriefing allows you to actively reflect on what you just did, how things went, and it enhances your learning. And then finally, over time, it builds community. Coming together to reflect, hear perspectives from other team members is incredibly important. There really aren't a lot of high-performing teams out there that don't debrief in other domains, yet in healthcare and EM, we certainly don't do it often enough. Sometimes we just need to hear how we're feeling. The case could have been tough, but we're in it together. No one else will understand what we experienced, and we should take advantage of this time together as a team. So when should we debrief? Well, I definitely don't think we should debrief only the cases that had poor outcomes. This represents less than 5% of our cases. In fact, the case I presented at the outset actually went quite well, at least in my mind, but that's the key, in my mind. I have no idea if it went well in the mind of others, or maybe it went well because a team member had to develop a workaround and we kind of just got lucky. For example, maybe the porter didn't come to get the blood and instead the nurse went and got it. The outcome is that we got the blood in a timely manner, but that's not the proper process. Some cases go very well, and that may be because we all performed as expected, or because we got lucky and we didn't really perform very well, but it just worked out. And then sometimes cases go very poorly, and that may be because of a single issue or multiple issues, or like we're all familiar with, we literally do everything possible and still the outcome is suboptimal. But in each of these situations, there is value to debrief. So you just have to pick a few of them. Finally, I think we should debrief and celebrate successes. Even if it's just 5 minutes of, hey, any initial reactions? Wow, we all performed incredibly. Great. Would you change anything? No? Amazing. Thank you to each of you for your incredible effort. Okay, I think we can get back to work. So for me, I pick a variety of cases, some that go well, some that don't. And particularly ones where the outcome doesn't match what I expected to occur. I also do typically focus on resuscitations because they're much more complex and involve the most people, but I'd love to hear from others about successful debriefings in other instances. Okay, let's talk about some barriers. What are the usual barriers that people mention for why they don't debrief? I'll address the top 3 that I hear most of the time. Number 1 is time. We don't have time to debrief. It's simply too busy. I know, it's not easy. But valuable things aren't often easy. I'd suggest reframing how we think about resuscitations. We should just think about the debriefing as part of the patient's care. It's how we take care of our team. We don't stop a resus because there's other less urgent patients to see. Consider wrapping the debriefing into the resuscitation. We need to build over time a culture that says it's okay for people to take 15 minutes to debrief. Normalizing this behavior happens from both frontline workers as well as ED leadership. By debriefing, we're saying we're prioritizing our learning, our team, and our desire to improve. Commit to short debriefs, and if not everyone can join, that's fine. Don't let perfection be the enemy of good. I hear, I don't have skill. I don't know how. Well, we're going to talk about that in a minute, but honestly, just get your team together and ask any initial reactions from that case. Sure, it's great if you've taken a debriefing course, but you don't have to. Just try it and you'll get better over time. And third, culture. I hear things like, our site doesn't do this. Okay, fair enough. But when you're working, invite people to join, run a debrief, make it optional, but start the process. Take the field of dreams approach. If you build it, they will come. People don't like missing out on things. And then let your leadership know that you did a debrief a case and celebrate that. Normalize the process and it'll grow. Okay, so you're mildly convinced, maybe. Well, how should we get it started? I like the info framework, and I'll talk about how I would debrief the case we started with. First off, the info framework's from a team in Calgary, and info is an acronym. I is for immediate. Do it as soon as possible after the event. For a case like this, I'd probably make an overhead announcement, or if I had the team with me, I'd say, okay, let's meet back here in 15 minutes. Sometimes do it right away, but sometimes that can feel a bit early as people have other clinical responsibilities immediately after. N is for not for personal assessment. I start with saying this, that the point of this is to discuss how we all worked and not as a performance review. Rather, we're trying to understand what went well and what didn't. F is for fast and that we'll seek feedback. And I'll start with just, we're going to take 15 minutes to get some initial reactions, and then we'll discuss anything that we thought went well or that we would change for the next time. And finally, O is for opportunity. At the end, make sure there's time for questions or clarifying what exactly happened. Ideally, the facilitator is someone different than the team lead, as it allows for a flatter hierarchy and I think better conversations. But don't let that be a barrier, and in many instances, it may not be possible. I actually often find that I end up facilitating even the cases that I lead. I recognize it's maybe not the best, but it just depends who's around. In tougher cases, we will actually have other docs or nurses who get briefed on the case, and then we do that a bit later. Okay, so we'll use the info framework, and I'll combine that with the Pearls framework, and I'll include those in the show notes. And what does that mean? We'll start with the following. Okay, that was a tough case. Brought all of us together for over an hour, and I found coming back together to debrief can be really helpful. I want to take the next 15 minutes to discuss how it went for everyone involved, because sometimes I'm not always aware of everyone's perspective, or there are things that need clarification. We're not here to evaluate individuals, but this is about just sharing thoughts, and there are some, system and process items that went well or that need attention. At the end, we'll make sure everyone's had a chance to speak if they want. We'll try and clarify any uncertainty, and then we may have a few takeaways. Okay, so any initial reactions? At this point, I just try and get people talking. And then I'll describe the case in a summary form to make sure everyone knew what happened. Just so everybody's clear, this was a 64-year-old male who presented with EMS. He was hypotensive. We had to intubate the patient. He needed blood. He received a chest tube. We gave TXA, and we got him transported to Definitive Care Trauma Hospital. It's amazing how some team members who are very task-focused may miss entire elements because they just aren't able to concentrate on everything that's happening. And that's totally normal and okay, but the summary helps us get all on the same page. After that, I'll move to a plus delta. What does that mean? Well, let's talk about our team performance. What went well, the plus. What didn't, or what would we change, the delta. From my perspective, in this case, I might suggest we focus on 3 components. Let's talk about the intubation. I want to make sure the MHP activation went okay, and the chest tube insertion process. And then I'll ask, are there other things that we should discuss? And then finally, after we've complete that, any follow-up? Or maybe any takeaways. Yeah, we maybe recognize that we shouldn't have the nurse going to get the blood. We should actually have the porter, and we'll have to look into that. Okay, there we have it, debriefing. Hopefully that helps. That's how we run these at our center. I remember a case in the past year that we debriefed at about 4 a.m. The team was outstanding. We got a trauma patient rapidly to the OR after intubation, art lines, MHP, central line, all of it. It was crazy. And in fact, there was a successful thoracotomy. The team just came together and really ended up talking about how proud they were for each of their contributions. It was awesome. We didn't have a lot to change, but it really helped build trust and a sense of community. All right, so here's my challenge to you. Debrief one case this year. See how it goes. Don't set the bar too high. It's hard to debrief every recess. Sometimes it doesn't need to be, but if you start with one debrief, it's one more than you did the previous year.
All right. Well, hope you all reflected a bit on your practice and learned some pearls about post-tonsillectomy bleed. Remember, when the bleed is delayed a few days post-op, even if it's just a little trickle of blood and it settles in the ED, all of those patients need an ENT surgeon for source control. And for post-CABG surgical incision infections, even if it looks pretty superficial, assume it's a deep chest infection until proven otherwise. When it comes to using Bougies, there is good evidence for improved first pass success, but only if you're trained properly and have practiced the nuances of how to use it. So do go ahead and practice those nuances. Consider an occult bleed in all your pelvic fractures, not just the big trauma ones, and try debriefing cases with your team to improve performance. All right. Hope to see you all at the online International EM Cases Summit, November 21st to 23rd. We already have about 400 registrants, so don't miss out.